topic is going to be on palliative care within ICU, which is very topical on our side at the moment, especially today. I'm Nisha, for those of you that don't know me. I'm one of the ST6s in anesthetics and ICU. So during my time in renal medicine, I ended up spending about a month as part of the palliative care team over on the Glenfield site, which is why I'm doing this talk. So very important topic. So it's a really broad topic, as you can imagine. So not going to be able to cover like all the kind of details, but what I'll try and talk about is what is it sort of in a snapshot summary, what is it specific to within the realms of intensive care, how do we measure things like quality of life, and why is it that it's quite complex on ITU. What I'm not going to talk about is the SWAN care pathway, because it's a massive booklet with lots of things that we have to fill in. And it's pretty self-explanatory, which is why I'm not going to go through that. So when people hear palliative care, there's a lot of assumptions that are made. So people will assume it means imminent death to the patient involved. Actually, not always, as explained by our case study today on the unit here. I'll kind of talk to you guys on the Glenfield side about what happened at the end of the talk. The reality is that palliative care means we switch the focus to symptom management, prioritizing the patient's quality of life, providing sort of pastoral support and care for both the patient and their family, and lots of preparation and planning about where the patient is going to go in terms of, depending on how near the end of life they are. Is it a case of they stay in hospital? Is it a case of facilitating movement to a hospice? And if they are going home, what sort of things need to be in place for that to happen? And they're really, really good at, as a team, at having the really sort of awkward conversations, especially with the more complicated ones that are not as straightforward. So ICU specific issues with end of life care. I think the problem is you'll have someone who is admitted to ITU and they may be anywhere within the course of illness, which is like we might literally get them at this point, which is just seconds before death, or sort of somewhere around this part, which is where actually they could kind of go over the cusp and die, or actually we bring them back from the brink. So I think the fact that we tend to have patients where we're quite uncertain about their prognosis and outcome can complicate things somewhat. We're dealing with constantly evolving physiology, really rapidly changing scenarios. And often our patients have, like the very nature of ICU means that they come to us and they have a lack of capacity. So they may be intubated, sedated, they may not have any advanced wishes specifically in place. So we often have to make really challenging best interest decisions. So how do we measure quality of life? So the things that we tend to focus on from a medical standpoint is physical and mental aspects to quality of life. But actually, there's loads of other bits to quality of life that, you know, if you look at it on a more sort of global scale, there's socioeconomic factors, there's things like their basic security and freedom, which contribute to quality of life. But when we hone down into the medical things we focus on, which is physical and mental, there aren't really that many validated questionnaires that you can really use for it. There were two that I could find that were ICU specific. Annoyingly, they're behind a paywall, so that means you end up having to take out a subscription just to use them. And they're named really awkwardly after, to me, what sounds like Star Wars characters, hence the reason for R2-D2 and C3PO. But from looking at them, the kind of 5 things that they focus on is the patient's mobility, their ability to self-care, what things they can usually do for themselves, and actually are they able to continue doing those things for themselves, level of pain and discomfort, and importantly, psychology, the level of anxiety, depression, distress that they may be suffering from. So those are really the kind of broad things we look at for quality of life. But again, there's no really clear validated questionnaire per se that we can use. This was a really complicated case. I've not put all the details in on purpose because it was just kind of to put it there to broadly illustrate how complicated it can be on ICU when you're dealing with a near end of life patient. So this was some of you at Glenfield actually might know exactly which patient this is in reference to. A 30-plus-year-old female. She had a rare genetic condition, was admitted to ICU, had a tracheostomy, really difficult respiratory wean, very deconditioned, reliant on NG feed. She was an end-stage renal failure patient to begin with, so she was already dialysis dependent, but she has a non-reversible pathological process. So the main issues with her and family were breakdown in trust with the system. There was a real refusal to believe that her decline is permanent. But actually, when delving deeper into the sort of concerns and issues of her and her family members, you find out that they've lost multiple other family members to the same disease process. So it's not so much that they're in denial because they didn't understand that it's a progressive, non-reversible condition, but the psychology of dealing with multiple bereavements within a short period of time, which is why I say when looking at the bigger picture, like I think we're quite good at focusing on like the medical side, which is, you know, you've got a condition, these are the things we can do for it, these are the things we can't do for it. You know, 1 + 1 = 2, but actually the other bits, when you're dealing with next of kin and a patient who's actually compos mentis and able to communicate, it can often get lost, especially with end of life. So this was just to illustrate that. So like we said, so how do you deal with dilemma regarding end of life on intensive care? So if we have someone who's coming in with a severe acute illness and we're really uncertain about the prognosis, the most important thing is being as clear and as honest as possible about that uncertainty. So avoid making any firm predictions, and avoid kind of making any promises, because that can often lead to misunderstanding and conflict later down the line as things change and if they change. Are there any advanced statements? So sometimes the patient might have had this formally put in place according to their values and wishes. Sometimes they actually express those wishes to their next of kin, which makes our life a bit easier, because then if we're able to have that honest conversation with them, it usually guides us as to where we can go. So in terms of the treatments that we're offering, would they then offer a minimum quality of life that is acceptable to the patient? So can we get them back to either their baseline or a baseline that is acceptable enough for them to achieve a good quality of life. So again, if the family are challenging the prognosis, it can be quite difficult. So it can be quite difficult for the team. It can be quite difficult for the nurses. It's quite difficult for everyone, really. And essentially, it's just taking it back to like the 4 ethical principles. So whatever it is we kind of discuss and decide as a team is what we're doing in the best interests of the patient? Are we being just in what we're providing, or is it something that is medically futile? You know, is it something that is going to cause harm? So we don't want to cause harm to said patient. The Intensive Care Society have put some really good sort of flow charts just in place for how to approach that kind of situation. So if there's no consensus about end of life care, then the next kind of step, importantly, is having an MDT approach. So that's the family, the ICU team, the nurses, the referring team, and then seeking additional opinions. So that may be from an additional specialty or consultant, and getting their sort of external additional opinion. If a consensus still isn't reached at that point, there is a clinical ethics committee. So they act as external mediators. So they'll kind of look at everything and try to, you know, help everyone come to some form of consensus. If there's still not a consensus, then seeking advice from the hospital's legal team. And then the last thing, which you really don't want it to come to, is where it goes to court. But ultimately, the end kind of goal is to have an individualized end-of-life care plan for that patient. What are the principles of a good death? So we may not be able to achieve all of these things, but we can try our best. I think certainly points 2 and half of point 3 we can potentially do on ICU. So the ability to know that death is approaching, I think that's more like in ICU, that's probably more for the actual relatives, the next of kin, rather than the actual patient themselves, because they may be sedated, multi-organ failure, multiple forms of support. Physical and psychological symptoms, I think, has been drummed into us quite a bit. And importantly, the right to die in a dignified manner, in a place that either they or next of kin choose, without unnecessary prolongation of their suffering. Again, another sort of flow chart on ICU. So there's all the sort of like fundamental aspects to end of life care that I think we're all kind of well aware of. So looking at their symptoms, and it's purely symptom control at this point. So that's this box here. So all the fundamental things that we are used to dealing with in an end of life patient. The really sort of ICU specific things are here and here. So if they're on any inotropes, vasopressors, and again, this will be an MDT discussion, but do we stop those? Do we stop things like filtration? Do we, if they have invasive ventilation on board, do we continue to suction? Because that in itself, that act itself can cause distress. And then actually how we're going to facilitate the withdrawal of their respiratory support. So are we going to extubate them, or are we going to simply, I say simply, it's not that simple, but are we going to switch the ventilator off? So this box here is quite nice in sort of guiding what we do for respiratory support. So making sure alarms are off, because that can be really distressing. Reducing steadily the amount of support they're on. So it's kind of like a gradual graded thing. Reducing their inspired oxygen, reducing their rest rate, their tidal volume. And then at that point, again, you're sort of guided by the patient's kind of clinical snapshot. Like if you look at them, if they look settled and comfortable, and a lot of this will be discussed with the family as well. It's deciding, do they want to be there at the point when you're extubating this patient? And I think it's really important just to kind of pose that question to them and explaining the steps of what to expect to them also, so that it doesn't come as a surprise when you're taking the tube out. If the patient then is sort of agonal breathing, it's explaining that process to the relatives that are going to be present, the next of kin that's going to be present. Other things that are important, like as mentioned, making sure the family are well supported. Spiritual needs, a chaplain's really a really good kind of service. And here on ICU, they've got like there's various things they do for sort of memory making, but the nursing staff are really good at that. And again, they kind of go through it with the family. And then yeah, obviously after death, there's ongoing sort of bereavement services for the next of kin. And then just making sure you kind of check in on everyone within the team as well that's been involved. So like the nursing staff, whoever's kind of been there actively withdrawing things if there's been an act of extubation, for example. So support for the family, support for staff as well. There's some really good tools online. So this, again, as much as you kind of want to explain to the best of your ability what to expect for family, it's really overwhelming. Sometimes actually they like come back to you and they ask you to repeat things, because even if you're like the best communicator in the world, it's such an overwhelming time for them that they will come back and just ask for things to be repeated. And they, sort of pointing them towards resources that may help guide them if they have specific questions that aren't being answered. So there's this on the left, which is an patient charity called ICU Steps. And I think the one on the right, I think I got from the Intensive Care Society. I can't remember where I got that one from. I think it's from the ICS. So just to summarize, importance of emphasizing an individualized care plan. So no patient's going to be the same. Even if your kind of end goal is the same of symptom management, the way you go about it's going to be different. Helping patients and their families to have as much control as you possibly can. And I think a really important thing that they do as part of the palliative care team is this thing called a parallel approach. So even if we're continuing with certain things treatment-wise, if we feel it's potentially futile, having the anticipatory meds there in tandem while we continue said things. So the whole parallel approach of we're continuing with these things, but we think they're still potentially going to die. So we also want to get symptom control. So we've got the anticipatory meds on the side. And it's explaining that to the family as well. We're trying, but we've got a low threshold for things can go south. And we want you to be aware of this. And we're going to try our best to control symptoms at the same time. Be respectful of their spiritual and religious needs also. So again, like I said, chaplain. And yeah, palliative care team, honestly, I think are your best friend in this kind of situation. So like, for example, the case we have on the unit at the moment is a man with a hemorrhagic brain mass who got extubated yesterday afternoon. And he hasn't coned, he doesn't have midline shift. He's got a really poor baseline. So the reason we sort of even brought him to us was just to facilitate withdrawal. His next of kin was really clear that he does not want anything further invasive doing. So no sort of surgery, wants to pass with dignity. And over the last 24 hours, what's changed is he's now basically jumping out of bed. But we're trying to kind of get control of his agitation at the moment, and we're trying to get him to a point where we can facilitate getting him home with his family. But the end goal or the aim is still the same. It's trying to let him get to a place where he can pass with dignity, but it doesn't mean he's gonna like die today or tomorrow. We don't know. I mean, he might. But yeah, having a plan in place for that. So that's just one case we're kind of dealing with at the moment on the unit. Thank you. That's a picture of a sunbathing cat, because why not? Does anyone have any questions? So it was a really challenging one. So in the end, she went to they managed to wean her enough to the point where she went to one of the respiratory wards with NIV and was having hemodialysis, like going back to the renal ward for dialysis sort of 3 times a week, and then deteriorated, and then she ended up like dying of, I think, a HAP on the renal ward in the end anyway. So, but she was at that, there was a bit where she was at that point where trying to establish what her kind of goals and wishes were was really challenging. So yeah, that was a tough one.
Can you have a patient like on that level of support?
Yeah, and I think that was the challenging thing, because she's awake, she knows what she wants and she knows what she doesn't want, and it's respecting that, and like hence the whole point about the individualized care plan, because what might work for one patient may not work for another. Yeah, so we're
we can't go beyond that anyway. When family is prepared and we want to give him like dignified death or end of life care.
Yeah, so with him, because
Like,
he's not
go beyond that.
Yeah,
Restricting us to go to take that step.
so yeah.
So if your patient is sedated and not agitated, then you can't give more than you want to give them. And the difficulty with him actually, we reduced it very slightly, and it doesn't actually get the converse effects. We give too high agitation and you actually get increased agitation rather than reducing. But it's really important legally that you give drugs with the primary intention of relieving pain and suffering, not with the intent of ending nothing.
So if we can give propofol bolus.
I don't know if you guys can hear that on the Glenfield side. Jenny's just basically saying, the whole purpose of the sort of end of life drugs we're giving is for no, sorry, I was just summarizing what you were saying. Yeah, is for symptom management and not like trying to speed up or expedite ending their life. So because the patient we have on the unit at the moment, we initially he was really agitated, and we felt that actually and he was on 5 milligrams an hour of morphine and midazolam as an IV infusion. And actually the next step we were discussing with the palliative care team was whether he would need a phenobarbital infusion syringe driver to get him home. But actually what has changed is he's actually come round. He's actually rallied. So what we're doing now instead is we're trying to wean his morphine and midazolam infusions and using PRN levomethomazine instead, like to help the agitation. And we're just trying to see if we can get him to a point where he's not as reliant on the IV infusions, and see actually if we might get him to a point where we can get him home somewhat settled. But I think the problem is we just don't know how fast his end of life process is going to be. Hence the point that like we made about it's a dynamic, changing situation, rapidly dynamic. Yeah.
Sounds like it's a good job you have an issue with your expertise. I think
trying.
the guys at Glenfield have got their hands up.
Hi, thanks for the presentation, Nisha. Just had a small question. Since you said you did some palliative care as a process as part of your renal rotation, I was just wondering if they have any guidance on hydration and thirst management for these patients. I know that in intensive care we tend to stop things like nutrition because that tends to prolong their death. But if you have a comatose patient who's not able to, who's extubated now, but not able to say he's thirsty, and you've stopped IV fluids as well, are we letting the patient die in thirst, or is there any guidance regarding hydration, oral or NG, water, anything like that?
So the thing that I was kind of told by the palliative care team about that was if the patient's already got a route for hydration, so like if they've already got an NG tube already in place, then you've already got that invasive sort of thing that's already in place. You're not putting a new one in for it. So you can, it's kind of, again, it's an individual thing. Like you can just continue it. You can just continue fluids and hydration if it's already in place. But having said that, if it's a case of giving them fluid and hydration may potentially make symptoms worse. So like if, for example, like the fluids going to their lungs, like if they're then just starting to become more respiratorily, what am I trying to say? Like respiratorily compromised, there's a better way to say that, then actually just like, then yeah, no, stop the IV fluids. But they also say, and the palliative care team, if it's something that's really distressing the family, because they're like, oh, they're not getting fed. Like there's a phrase that they use, which is there's no point falling out over a bag of fluid. So just keep it going. As long as it's not causing the patient distress, I think is the main thing. And just like communicating to the family that at this point in time, they're so out of it and comatose, they're not feeling the thirst and the hunger. Priority is different. Obviously, if they're awake and they're asking for it, that's a different story. Then just give them whatever they want. Yeah, just give them. Yeah, exactly. Just give them whatever they want.
Yeah. Thanks for that, Nisha. I think the practice that we do is if we decided that the patient goes on to the end of life pathway, we tend to stop nutrition, fluids, IV hydration as well. But I think what you say makes sense. It's not actively prolonging the causing any harm. It shouldn't be giving the patient fluids to maintain hydration. Hello everyone, my name is Gautam Srinivasan. I'm one of the fellows working at Palliative Care. Journal club for this week is this study that looked into how we use echocardiography management of shock from an intensive care perspective. So Glenfield and Mr. Royal were involved in this as well, and there were a lot of known names in the collaborators section. So this study was published last year in Intensive Care Medicine. This is from audits conducted by the TRIC network, which is basically trainees research and intensive care network, society, faculty, and British Society of Echocardiography, all stakeholders. So, coming to introduction, echocardiography is recommended as a first-line imaging investigation in undifferentiated shock in a couple of societies, including the European Society of Intensive Care Medicine. So, this study was basically intended to see as a snapshot of how we use echocardiography in the UK, the current provision and utilization of echocardiography, and how it affects management in decision making in intensive care, and are we really adhering to the current guidelines of documentation and image storage. So it was a multi-center prospective observational study, and mainly just wanted to take a snapshot picture of how many and how we're using the echocardiography, and is it impacting decision making. So it's a prospective multi-center observational study population where intensive care in the UK, I think 178 centers participated. Anyone about the age 18 and admitted with shock was enrolled into the study. Since it was like an audit, they didn't have to get consent from patients. They got the IT clearance, and the study went on for like a 7-day period between 4th of March and 21st of 2024. So when the patients get admitted at R0, and if they're diagnosed with shock, so they're reviewed at R1, R24, and then R72. And the following data were collected basically. It was seen what time patients were admitted. Was it in hours or out of hours? Or whether an urgent echocardiogram was indicated on the primary assessment on admission, or whether an echocardiogram was performed within 72 hours of the decision to admit. So this was one of the primary objectives, to see if patients who were asked for an urgent echocardiogram, did they ever receive it at least within 72 hours. And the nature of the echocardiogram performed as well. Was it a bedside one? Was it a comprehensive scan by the cardiac technicians? Whether echocardiography helped in making the diagnosis or changing the diagnosis and changing the management. Most of the categorical variables here was analyzed by chi-square test. They used our statistical software as well. Results from the study. Results were from 128 centers. Over 1,000 patients data was collected, which 37% of patients were admitted in hours, 41 were admitted out of hours, and 22% were admitted during the weekend. And the last bit is a bit of how much the different shocks that we deal with. 36% is distributive shock. I guess most of that would be septic shock, be hyperactive or neurogenic. 21% being hypovolemic, another 21% being cardiogenic, 2% obstructive shock, and a fair bit, I would say 20%, 1/5 of the patients were on mixed shock. Yes. Vision of echocardiography. So of the bit over 1,000 patients, echocardiogram was performed within 72 hours in only 54% of the patients. So this is quite significant. So even though these patients were admitted with shock, only 54% of patients received a scan within 72 hours, of which 43% received within 24 hours and 7% received within an hour of admission. A picture to the right is the heat map of the UK with the proportion of patients who received echocardiography, with yellow and light blue representing high proportion patient, with deep purple with the lowest proportion patient. Scan delivery, of the 545 patients who received scan within 74 hours, 58% of the scan were delivered by the critical care team, who were credited in bedside echocardiography or other advanced echocardiography. So 67% received a focus scan and 33% received comprehensive scans, and 1% received TOE. So focused echocardiograms are performed slightly earlier than comprehensive scans, but for obvious reasons, because it's bedside and earlier. Of the total scans, only 56% of the scans were done by clinicians who were accredited. Again, a heat map in the UK with the proportion of scans done by personnel working within the critical care. So if you look at the previous map, look at Southwest. Southwest scanned more number of patients proportionately, but most of the scans were done by not by personnel working within the critical care. So probably they have any form of echocardiography service within their setups, but this is me speculating. Echocardiography resulting in change to the management. It's probably the most important slide here. So echocardiography was reported to reduce the diagnostic uncertainty or change management in about 54% of patients. So if you see the different bars here representing the types of shock, purple is no echo performed, and green is where the performed echo resulted in a change in management, and yellow is where no change in management was done following the scan. So cardiogenic shocks and obstructive shocks had a good proportion of patients whose management had to be changed after the scan. I think that's reasonable. And the next would be mixed shock. What is notable here is, irrespective of whatever shock we think we are dealing with, could be hypovolemic or septic shock, there are a certain number of patients who benefit from scanning, and a change in management plan has been noticed. Last bit is adherence to documentation and image storage according to national guidelines. Free text report, which is most often the case, it was soon about 54%, and the structured report in about 39%. 7% of cases did not have report documented at all. Images were stored on the ultrasound machine in 39% cases, digital archiving systems in 33%, not stored at all in 39% cases. And I didn't know that you're supposed to write the location of image storage as well. So location of image storage documented was only about 24% later. So in summary, only about 25% of the echocardiograms was the documentation of the echocardiograms was compliant with the national guidelines. Strengths of the study, so had a large sample size, about 1,000, good participation, good numbers, 178 centers. It's a prospective study, so it reduces recall recall bias and standardized data collection upgrade. Limitations of the study did not specify the exact nature of change in management or the result of the echocardiography scan, which changed management of the patient. And it did not tell about any long-term benefits of the echocardiography scan, as we only followed up for 72 hours. There's a possible selection bias as units which are interested in echocardiography may have been more likely to participate. There's a potential outcome effect as well, where the awareness of being studied changes how you behave during the study period. The study did not look into the accuracy of interpretation, or the quality of images, and did not look into the barriers of echocardiographic permission as to where all units did all units have echocardiography machines? Did all units have staff and faculty who are trained in doing bedside echocardiography? So if there's 2 points I want to take away from this study, it's that only 54% of patients received an echocardiogram within 72 hours of admission, and echocardiography was reported to have changed or altered management in about 54% of patients. This is a task checklist I've gone through. Given the nature of the study being observational study, some of the questions here are quite generic for cohort studies. They do not fit in right well, but nevertheless, I've tried to put them in boxes. A couple of questions I've answered maybe and no, only because there could be possible biases from the fact that the study didn't account for any availability of echocardiography service within the hospital. For example, in the southwest regions, as I mentioned, or the accuracy of interpretation, which would have all changed the numbers. At 54% would have changed. Not a criticism really, but so I think this is the essence of journal club. Should we change practice? Yeah, in this study, based on this study, the question would be more: are we scanning all our shocked patients? That is the question. And for us in Glenfield, being a cardiac unit majorly, most of our patients come out with 2 or 3 inotropes, or at least one, and they come with a scan report. We start a scan report at the admission. So unless something has changed in the next few hours, as in the drain outputs go high, the vasopressor requirements go up, or patients decompensate from a lactate or metabolic point of view, we do not scan them. So saying that we admit our patients with scans, I would say we are scanning most of our patients. And then patients who are non-cardiac, if we admit patients from the ward are from a perio situation, or patients who are not respiratory, if they are shocked, I do think we scan them quite often, but I wouldn't say we do it within the hour. So I've come back to that one particular graph that made more meaning on my thank you slide. This is what it meant to me. Irrespective of the nature of shock, echocardiography will at least help you alter or optimize your plan, or at least confirm your beliefs.